so the lights. That's good. All right. Yeah. Can you hear me? Is this okay? Yeah. It is? Oh, I'm sorry. Sorry, I wasn't paying attention. Sorry. So, good morning, everyone. Welcome to the last section on brainstem anatomy. We we are going to deal with the last bit of the brainstem today, the medulla. And it's very different. Like every part of the brainstem is different from the other parts. So this medulla is very different from the pons and the midbrain. And my job today is not to give you a lot of information, but kind of to familiarize you with how to identify the medulla, where the important tracts are located, and maybe look at the physiology a little bit. So we're going to go into the details of some of that. What's important to understand is when we started with the midbrain, we were looking at important functions related to vision and hearing and things like that. And you come to the pons, and then there's facial sensation, facial movement, and stuff. So you see how we're going down. Now, when we come to the medulla, it's all below the neck mostly. It's all visceral functions. So this is the localization of these functions in the brainstem is more diffuse than the pons or the midbrain, and therefore it may appear a little confusing, but you should stress only on the important aspects of this. There are a lot of overlap between the cranial nerves, which does not happen in the pons or in the midbrain. They have very specific functions there, but when we come down to the medulla, there's a lot of overlap. They share the nuclei. And I'll tell you why that's important. But remember, the key is the visceral functions in the medulla. So you have things like taste, gustatory functions, respiration, cardiovascular functions, swallowing, stuff like that, yeah? So we look at the basic structure of the medulla. Now, when we did the midbrain, remember, I stressed on the fact that you should identify the section by the CSF space that it's showing, right? So the cerebral aqueduct was the most important feature in the midbrain. But when we came to the pons, it was the open fourth ventricle, which wasn't bound dorsally. When we come to the medulla, it has interesting features which are similar to the pons, and the lower medulla is similar to the spinal cord. So it changes. The upper medulla is a little different from the lower medulla. And therefore, it's important to differentiate between the open medulla and the closed medulla. The open medulla is very similar to the pons because it's transitioning from the pons to the medulla. So it looks a little similar to the pons, but there are important differences, and we'll come to that. And if you look at the lower medulla, that's here. It does not have, it's the only part of the brainstem which does not have a prominent CSF circulation pathway. The lower medulla does have the central canal, which is often too small to be seen in sections, just like the spinal cord. And even in radiological sections, sometimes you can't see the central canal because it's really small. So I wanted to just stress on this a little bit. And you can see here that's the fourth ventricle, and how the medulla continues beyond the fourth ventricle down there. So until the apex, the inferior apex of the fourth ventricle, it would be the open medulla, and below that is the closed medulla, right there. And from the lateral view, you can also see that here, although this image is a little deceptive because it shows a large central canal here. It's not that big. It's a really tiny canal which goes to the center. But you get the idea, right? So it's open all the way from here, pons, up to the upper part of the medulla, and then it gets closed down there. Right. So I put this image so that you remember we've been through this one before, just to give you an idea of how we can correlate some of the external features with some of the internal features of the medulla. So like the pons, like I mentioned, you have, this is again a junctional section. This is not something you're going to be quizzed at. It's not the typical section of the medulla. And I like to put these junctional sections again to stress the point that there is a transition from pons to medulla. There isn't a single point where you can say the pons stops here and the medulla begins, because a lot of the tracts and fibers continue in the medulla as they were in the pons. But they're important transitions, so I wanted to stress a little on that. And you can see this part, because it's a transitional slide, that the fourth ventricle's dorsal there, it's an open fourth ventricle, and then you have the peduncle, the lower part of the peduncle. But there are important new features which you can see here, and one of them is the start of the pyramid. So I'm just showing the important ones. I'll show you the transition in the other slides. We'll go structure by structure, but the important things here is the pyramid. And you remember in the pons how the motor fibers were. They were in discrete fascicles with the transverse pontine fibers that were separating the different fascicles. Now, in the midbrain, you remember that the corticospinal tract was a solid structure. It splits up into the pons and then comes together again in the medulla. So that's important to remember. And that forms the medullary pyramid. Okay. And there is a new structure here. I'm sure you have studied or read about this a little before. It's the olivary complex, or the olivary nuclei. And that begins to be just seen at this section, because this is upper medulla, and we will see how it appears in the lower medulla. But the very important distinguishing feature of the medulla. So if you see this, something that resembles probably an intestine or something, is one of these variegated, curvy structure there, and that's the olivary nucleus. So if you see that, that's the medullary section. And then you have the medial lemniscus here, very important, and we will discuss about how it comes to lie in this position, because you remember in the midbrain it was close to the corticospinal tract, and now it's beginning to go dorsal, and we'll talk about that a little later. The one important thing I wanted to stress, which we didn't discuss too much yesterday, was the location of the medial longitudinal fasciculus. Now, remember that the third, fourth, and sixth cranial nuclei, they are at the ventral aspect of the CSF space in the brainstem, and very close to that, close to the midline, lies the medial longitudinal fasciculus. So I don't know if I stressed too much on that yesterday, but this is quite a it's the place where you can find it, or you can look for that over there. When we come laterally, you can see some of the cranial nerve nuclei here. So you have the vestibulocochlear nerve going out this way, laterally. And you have the spinal nucleus of the trigeminal nerve there, and the facial nerve. So all the cranial nerve nuclei are mostly in this place, located more dorsolaterally. Yes. And so we'll look at some of the other sections. Now, I put this for reference to see how the structure of the brain stem is actually changing from rostral to caudal. So this is how it was in the midbrain, and you see the aqueduct there, and this is what happens, representative section of the pons with an open fourth ventricle. Now, the medulla also has an open fourth ventricle dorsally, but how this differs from the pons is that you do not see this bulky middle cerebellar peduncle, which is not present here. You have a bit of the inferior cerebellar peduncle, but it doesn't look as bulky and big as the middle cerebellar peduncle. So that should give you a hint that we are in the medulla and not the pons. And okay, so we look at this, some of the interesting features here. Now you see, as we go down the medulla, the pyramid becomes larger and larger. So we'll see that's because of the decussation, the way the fibers cross over. And you see how big the olivary nucleus is over here. It's a complex nucleus with multiple nuclei, and the superior olivary nucleus is associated with the vestibular functions, and the inferior one with the cerebellum. I won't get into the details of all that, but if you know where it's located, that's really important. And so one other interesting fact about the medulla, when you see the sections, is that the pyramid and the olive, they form two distinct bundles on the external surface. And there's a little groove here, okay? And in this groove, on the lower section, you can see the hypoglossal nerve coming out. And that's a very standard landmark. And there's another interesting thing. You see a groove posterior to the olive here, between the olive and the inferior cerebellar peduncle. And in that groove, you have the other cranial nerves coming out. So at this section, we have the glossopharyngeal nerve, because we are at the upper part of the medulla, and as we go down lower, you'll see vagus also exiting out from the same region. So remember, the 9th, 10th, and 11th cranial nerves go posterior to the olive there, in the groove between the olivary nucleus and the inferior cerebellar peduncle, and the hypoglossal, which is a motor nerve, and we remember from that mnemonic 3, 6, and 12, all the motor nerves exit anteriorly, and therefore it comes out from this groove. Now, these are important things to remember. The medial longitudinal fasciculus again is in its expected position right there. You have the medial lemniscus, which looks a little larger here because at the lower sections it's going to decussate, and I'll show you that. You have two other important nuclei or nuclear regions of the medulla, which you need to know a little bit about. One is the solitary nucleus over here, which is a shared nucleus between the 7th, 9th, and the 10th cranial nerves. And it subserves some of the visceral functions that I mentioned. It's important to know that it's located here, posterior-laterally. You probably won't be quizzed on that. And then you have the motor component of the lower cranial nerves, which is the nucleus ambiguus, which lies here. So that's motor, and that's the sensory component there. We're still at the open end of the medulla, the upper medulla. And the reason I put so many sections today is because the medulla keeps changing, and it's interesting to see how that happens. So if you remember one standard section from the open medulla, that should be enough. And at the lower medulla, two important sections at the motor decussation and the sensory decussation. So I'll point those out. So this is again the open medulla. You can see that, and what's interesting here is at this section you're just about seeing this structure. This is a bunch of fibers that begin to cross over going into the medial lemniscus, and these are the internal arcuate fibers. So these originate from the dorsal nuclei, nucleus gracilis and nucleus cuneatus. Nucleus gracilis is medial and nucleus cuneatus is lateral, and they cross over. The crossing over is over a certain length of the medulla. So it begins at this section where the open medulla is still present, and it goes down. So this is an important structure to look for here. Okay. The other structures look about the same. Yes. One interesting thing here would be the motor nuclei of the hypoglossal, which you're seeing here. Remember, I mentioned the nerve passes out in this groove. We'll see that in a lower section. And also the vagus nerve, the dorsal motor nucleus of the vagus, which is also a motor nucleus. And on this image, you can see that these two nuclei lie next to one another there. Okay. And we are reaching the closed medulla now, but this is at the very apex of the inferior apex of the fourth ventricle right there. So you can see this region, it's called the obex, and this is the area postrema. The area postrema, if you remember from my earlier class, I mentioned that it's a very important area associated with vomiting, and you can see how that relates very closely to the salivatory nucleus, okay? Because it's about in that same region. You have those nuclei here, and you have the vomiting center here. So it's very close. So you have the gastrointestinal sensory nuclei there, and right next to that is the vomiting center, which makes sense, right? Because they are anatomically in close proximity. Again, some of the important structures that you see here is the nuclei at this section, the gracilis and the cunate nucleus become very prominent. This is the first section where you begin to see them, okay? And also you're seeing the decussation of the internal arcuate fibers there going to the medial lemniscus. Now, you are beginning to see the hypoglossal nerve here. So let me show you. So that's the nucleus of the hypoglossal, and then you can see the nerve bundles going down this way and exiting out in the groove between the inferior olive and the pyramid. So this is very, very characteristic. This is an important thing to remember. All right. Now we are in the closed medulla proper. Now this is a very representative section which you probably see on the test. This is the section of the sensory decussation. Now as we go down the medulla, we begin to see that it's beginning to resemble the spinal cord a little. And that's why I put up this here. There's some of the tracks which carry on from the medulla into the spinal cord, and then the newer ones that are added there. This is just a line diagram of the same, and you can see the decussation, sensory decussation being shown over there. Okay. The pyramids are beginning to enlarge here. They're quite large compared to the previous sections, and the olivary nucleus also is quite large. So you have 4 prominent areas. You have the dorsal nuclei, you have the inferior olivary complex, and then you have the pyramid. So you can easily identify this section as being a section of the medulla. And if you look at the internal arcuate fibers, which will always be present there, then you know that it's a section through the sensory decussation. Now this is another representative section which you could be quizzed on. You could have this on a test. And this is the motor decussation, very typical. And you can see these large bands of fibers which are crossing over. You'll be able to identify these. If you see this X-shaped structure here, you know you're in the motor decussation, all right? So this is very important to remember. The gracile and the cunate nuclei look much smaller now, okay? And you're beginning to see the fasciculi because we're going into the lower medulla. So you have the fasciculus coming up, which terminates in the nuclei, and then you have the sensory decussation. I'm sorry, I went for sensory, it's easier to understand if I go from inferior to superior. So if you look over here, let's just do that as an exercise. So you have the cunate fascicle and the gracile fascicle. These go up, and you see them something like this, where they're terminating in the nuclei. So you're seeing the nuclei here and the fasciculus as well, okay? And then you have only the nuclei, the fascicle disappears, and from the nucleus you get the second order neurons which are decussating there and entering into the medial lemniscus. And then the medial lemniscus becomes more prominent here, and as we go up you see that it moves more dorsally. So that's important to see how the dorsal column medial lemniscal system actually ascends up the brainstem.
And when it goes upwards, the brain comes closer
To the corticospinal peduncle.
all going into the capsule, right?
So it has to accompany that.
Now, the sensory, which is dorsal, starts coming anterior, starts coming ventral. So eventually the cerebral peduncle.
Yes.
They're going
Together, yes. So it's decussation and it's medial, then it goes posterior slightly and then starts coming back anterior. So I have another slide later. I'll talk a little bit. I'll show you that. That's quite representative as well. Yeah. So, so we are not going to look at too many of these things because, like I said, a lot of it, you even have the traditional names saying this nucleus ambiguous. So the medulla is a little ambiguous in that sense because it deals with a lot of visceral functions, not very clearly localized. So we're going to look at some of this, not too many things. Some of these are just outlined for interest's sake. I'm not going to cover many of these. We're going to look at some of the visceral functions. The olivocerebellar and the cerebellar peduncles will be covered in the cerebellar section. And so we start with one of the important sections, which is the solitary tract. Now you have the solitary tract and you have the solitary nucleus. Okay, the tract arises from the nucleus. It's not difficult to remember that this is related to the 7th cranial nerve. Okay, subserves the function of taste. So they are gustatory nuclei here. You have the 9th cranial nerve and the 10th cranial nerve. Okay, and then these would synapse in the salivatory nucleus, and the tracts go up into the thalamus and eventually into the insula. But you don't need to remember this pathway. Okay. Yes. So this is an important thing to remember. A little bit about this is the solitary nucleus. Now, solitary nucleus is from where the solitary tract begins. Now, this is, I'll tell you an easy way to remember this. So you see the nucleus is V-shaped, and in the lower medulla it comes together there. Okay, and at the apex of that is the area postrema, which is the vomiting center. Remember, so you remember V for visceral, V for vomiting, yes, and you can remember how these come together there. Now, a little bit about how interesting this is and how it's organized is that it's got different, from superior to inferior, it's got different sections. And the upper part is associated, the rostral part is associated with taste. So the 7th, 9th, and 10th cranial nerves. And then the middle section has got gastrointestinal receptors, mainly the vagus nerve. Okay? And this deals mostly with the gastrointestinal reflexes of the gut. And the lower part is more with the cardiovascular functions. So you have the carotid baroreceptors, the chemoreceptors, cardiac receptors, and pulmonary receptors. So all that's localized in the lower part. If you remember, the upper part's taste, the middle section's gastrointestinal, and the lower part is cardiac and respiratory. We'll delve on this a little bit more in detail because taste is so important clinically. When you reach the clinical sections, you realize that you can have a patient who loses taste sensations on one half of the tongue, and the anterior part of the tongue, posterior part of the tongue, and things like that. And that's important to know from the clinical neurology point of view. We won't go into all that, but just to understand how taste is subserved by the brainstem, the function of taste. So the anterior 2/3 goes through the chorda tympani, and this nerve accompanies it enters into the facial nerve. And this is a common phenomenon actually. If you study the brainstem more in detail, you see different aspects of different functions are carried by other cranial nerves. Now, there's always a controversy. Is that really a part of that cranial nerve, or is it just piggybacking a ride on that cranial nerve? But we are not sure. But it's important to remember that chorda tympani is associated with the 7th nerve, and that's taste for the anterior 2/3 of the tongue. The taste from the posterior 1/3 of the tongue is carried by the glossopharyngeal nerve. And you have other areas in the pharynx, like the epiglottis or the posterior pharyngeal wall, where there's some areas where taste is carried by the vagus. But if you don't remember this, it's okay. Yeah, so that's the cardiovascular receptors. We won't go into that. But I put this list here to make you just aware that there are a lot of these reflexes which are subserved by the solitary nucleus and the solitary tract. The important ones are the gag reflex and the cough reflex. Okay, and yeah, so we won't go too much into that. This is just a diagrammatic representation of the same, a little more about the connections, if you're interested to look at that, but not important from the exam point of view. And again, the same. So now, when you look at taste, taste has got certain areas, like I mentioned, of the solitary nucleus, which is called the gustatory nucleus. So if you hear this word, just understand and remember that it's part of the solitary nucleus. It's not an individual nuclei for taste, it's part of that. Okay? And it's got projections which go all the way up to the hypothalamus and stuff. So the salivatory nuclei are interesting and important, also a little complex in their connections, but we look at the basic thing. So you have two salivatory nuclei, superior and inferior. The superior one, again, is through the facial nerve, and the inferior one through the glossopharyngeal. So the facial and glossopharyngeal nerve have got similar functions when it comes to the visceral and GI tract, but different regions of that. So if you look at the superior salivatory nucleus and the facial nerve, it supplies postganglionic fibers to the submandibular and sublingual glands, but the glossopharyngeal nerve goes to the parotid gland. So some of the functions of these two nerves overlap. Yeah, and this is just how some of the tracts go out. So it's complex. I won't go into the details. We look at the jugular foramen when we are doing cranial nerves, but look, the inferior salivatory nucleus, for example, travels out, goes to the otic ganglion, and then you have the its synapse there, and then it supplies to the parotid gland. So that's basically what they do. The ganglia related to each of these, and then you have the postganglionic fibers which innervate the salivary glands. Nucleus ambiguous. The ambiguous nucleus, it was called because nobody was quite sure for a long time what function it subserves. But then because the functions are very subtle, and they are related to the GI tract, the visceral motor functions. So movements of the palate, the cough reflex, laryngeal movements, things like that, all are here. And so speech and swallowing, and it subserves that. It's a common nucleus for the glossopharyngeal and vagus nerves. There's a lot of overlap again between these two. But if you know the names, you know a little bit about it, that should suffice. This was what I was talking about, the dorsal column medial lemniscal system, and maybe just a bit of review on this. I put this image because it's quite interesting to see how the fibers travel. So you have the gracile fasciculus there and the cunate laterally, and always remember the gracile is medial, the cunate is lateral. Gracile comes from the feet, like Dr. Ulal mentioned, gracile for grass, or you can remember graceful, a person's graceful by the way they walk. So it's the lower limbs, which is gracile, and cunate is the upper limbs. And that's laterally placed. And then these ascend upwards, and then you have the medial lemniscus there. And you see how the medial lemniscus actually changes. And this is the decussation, I'm sorry. So it comes there, and that's the nucleus. It decussates there, and then from there it goes more posteriorly. It's not really going posteriorly, it's just being pushed by the bulk of the pontine fibers. So if you look at the relationship of the tract to the corticospinal tract, it's more or less the same, except you have all this additional stuff in between, and that's because of the transverse pontine fibers. And then it comes up here, and it's much closer again to the cerebellar peduncle, and synapses in the thalamus to the primary somatosensory cortex. Okay, I think I've already alluded to this a little bit, so we won't go again over this. It's the same thing. Now, this is just an interesting clinical condition, which I think you should be aware of. You probably have already has this been discussed before? No? Yeah. All right. Yeah, a lot of neurology is like that. You tend to forget. That's why I'm stressing on certain important aspects, and we're not discussing everything here. So that if you remember that stuff, that's good for you. Now, combined subacute degeneration is a peculiar condition. Just like we discussed, the central pontine myelinolysis is a condition which affects only the pons. And why some of these conditions affect only certain areas of the CNS is little difficult to say. There are lots of theories and hypotheses, but I don't think we know exactly why it affects this region and not any other region. Yes? So combined subacute degeneration, it's usually seen due to the deficiency of vitamin B12. And so why do you get vitamin B12 deficiencies? Any ideas? I'm sorry? Well, yes, that's the commonest one, because I'm from India originally, and I have vitamin B12 deficiency, but I never developed subacute combined degeneration. I had different symptoms, but it's very common in vegetarians. That's one of the things. We see that. And even in people who are taking a balanced diet with a lot of non-vegetarian food, they still develop this, and we are not sure why. There are certain conditions where you have certain factors in the gastrointestinal tract, like the intrinsic factor, which attaches to the B12 and carries it forward. If you have problems with those kind of things, you can still develop this. So what happens in this condition is that it very selectively affects the dorsal columns, and you can see that on this MRI. This is a mid-sagittal section of the spinal cord, and it's T2 weighted images. T2 because the CSF appears white, so that's easy to remember. And this is a transverse section at probably the upper cervical, and you can see that this you have this diffuse white area in the posterior part of the spinal cord that's going down all the way till there. And that's the area that's affecting just the dorsal columns. And you can see that more clearly when you take a transverse section like that, and you see this as the spinal cord, and you can see those bright white areas. Okay? Yes?
Wouldn't you expect bright white areas in the corticospinal tract also?
In the
Wouldn't you expect to see the bright white in the corticospinal tract?
cortical spinal tract? Yes, so that's what I was saying, that this particular condition tends to affect the dorsal columns more selectively. It doesn't affect the corticospinal to that extent. It affects the dorsal column, and therefore you get people who have ataxias more than actual quadriparesis or paralysis. And why certain neurons are selectively affected in certain disorders? Well, we are not quite sure. Let's put it that way. There are lots of theories, and when you go into clinical practice, you will see that there's a lot of research going on this, but we're not absolutely sure why that exactly happens. Yeah? So the corticospinal tract does not get affected to that extent like the dorsal column. And it's generally a very gradual disorder that develops. You can get some weakness, and usually nutritional malabsorption. If it's in its early stages, it's completely reversible, and it's quite a dramatic thing to see clinically when these patients recover. Yeah? I alluded to this a little bit before, but just the inferior olivary nucleus, just because it's such an important structure that you see in the transverse section there. And it's got a lot of functions to do with proprioception, with the extrapyramidal system. It's got connections which go up to the red nucleus. You don't need to know all this, but just to stress, you have to know a little bit about what such a big nucleus that's sitting in the medulla does. Okay, so it has connections with the cerebellum. So there's proprioception and fine motor tuning and things like that. And the upper parts of the nuclei have connections with the vestibular system. Unconscious proprioception. Yes, so conscious proprioception is the dorsal medial lemniscal system, and the unconscious one is through the olivary nuclei. So we looked at proprioception in various different ways, and you see how important that really is. You've got so many tracts giving you conscious and unconscious proprioceptions, because we don't realize this, but we are doing so much with our bodies and heads and vestibular system all the time that is there are lots of mechanisms in place to try and make sure that you're up and erect and seeing the three-dimensional world as you are. It's a very important aspect. Very briefly, I don't know if you've had this in the respiratory physiology classes about the different respiratory patterns, but very, very briefly, we won't go too much into the depths of this. But of course, if you look at we'll start from the lower medulla. Lower medulla, you have two respiratory centers. If you have a section there, it can be fatal. So there's respiratory arrest in the caudal medulla, okay? In the rostral medulla, you get what is called ataxic breathing, which is completely irregular breathing. So you can see these patterns in a comatose patient, okay? And ataxic breathing is like very irregular. The patient hyperventilates a little bit and then pauses a little bit, and then there's no definite pattern to the respiration. And you see this when there's an injury or there is a metabolic condition which is affecting the upper medulla, the open medulla. And then we did the PONS yesterday, and there's an apneustic center. Now, apnea is a condition that you use clinically when you say, the ventilator or the respirator is giving you an apnea alarm. That means the patient's not taking a breath, but this isn't the same thing. This is apneosis, a little different, where a patient's breathing and the breathing stops at full inspiration. So he takes a deep breath and then it stops that. You don't need to know the details of this, but I thought because we've done the brain stem, it would be interesting to see how the respiration changes with different levels of involvement of the brain stem. At the midbrain level, you get something called a central hyperventilation, and this is very difficult to control because the patient gets very rapidly tired. He's hyperventilating so rapidly that you have to sedate and induce motor paralysis just to get him out of this. And then, we won't go too much into Shine-Stokes and things because there are a lot of respiratory physiology that you need to follow for this. But just to know that different areas of the brainstem can cause different respiratory syndromes. I think this has been done several times, but I thought because the motor pyramids are so important, we just look at this a little bit. So the motor pyramid is actually the decussation that occurs from the corticospinal tract. And you know that already. And the way you identify it on the external features is the anterior median fissure here, or the sulcus, which continues into the spinal cord, and laterally on either side of that are the motor pyramids. You have, of course, we'll just go over this briefly. The primary motor cortex, that's where it begins and comes down through the internal capsule. This is the corticobulbar, I'm sorry. So you have the corticobulbar here, and then you have the corticospinal here. Okay? So this is the corticobulbar, which passes through the genu of the internal capsule. The corticospinal go through the posterior limb of the internal capsule, through the crus cerebri, and you see how it gets broken up here into various nuclei separated by the transverse pontine fibers, and this is the decussation that happens here. So I wanted to stress on this point. So you see how the fibers go here, and they decussate, go more posteriorly, and you get the lateral corticospinal tract here. Okay? So about 80 to 90% of the corticospinal tract decussates, and you have about 10 to 20% which goes in the anterior or ventral corticospinal tract. And this is basically showing you the same thing.
Where are they coming from?
Yes, that's right.
From primary motor, they don't synapse anywhere.
Yes, to the anterior horn cells of the spinal cord, yes. That's the place where they synapse. Actually, these are some of the longest axons you have in the body, because it's a single axon which is going all the way from the motor cortex all the way down to the anterior horn cell. So the lower part of the spinal cord, those axons which end there would be the longest axons, some of the longest axons in the body. And what's interesting about the motor decussation, because you can have important everyday situations where you have a whiplash injury, when a person's traveling in a car and somebody comes and rams him from behind, or you put the brake on suddenly and you have this hyperflexion, hyperextension injury, and there can be no external injuries, there may be no fractures or anything of that sort, but you can have an injury to the motor pyramids and the decussation. And this can be terrible because there's nothing you can do much about it except to help the patient with ventilation and things like that. A person can become completely quadriplegic without any external injuries because of the way the fibers are arranged. So, yeah. Sure. Yes, please. Yeah. Yes. Yes. So if there's an injury to the reticular formation?
Right, like at the medulla.
Yes. So the reticular nuclei are very, they're not discrete nuclei. They're kind of diffuse all over the brainstem to the tegmentum, the middle section of the brainstem, and they are both ascending and descending ones. And if you have an injury there, yes, it could lead to just a person being completely comatose. So yeah. But it's very hard to localize and say that if this part of the reticular activating system gets affected, it leads to coma, or this one doesn't, because they are not very discrete nuclei. It's more like, yeah, it's all spread all across. So I thought I'd keep it short today because it's a weekend. We have questions. Yeah, but the talk was, yes, please. No. No. So the syringomyelia is seen in traumatic injuries of the spinal cord, but not in all traumatic injuries. And it's usually the syringomyelia develops in trauma as a secondary manifestation. So you have an injury to the central part of the spinal cord. It's more complex because there's something called the central cord syndrome and all that. I didn't want to go, it's not required for you guys. But there's a complex syndrome which is called the central cord syndrome, where the injury occurs in the middle of the spinal cord, like the cervical spinal cord. And all those neurons begin to die over a period of time. And when you have all that space, that gets filled up by the CSF. So a traumatic syringomyelia is not something you necessarily want to treat, because it's not, like when a person grows old, the brain tends to shrink and the CSF spaces look bigger. That does not mean that he has hydrocephalus. But you can see the central canal in these patients after trauma, say after 6 months or a year, and you have a large CSF space in between, in between the tracts of the spinal cord. But that does not mean he has a syringomyelia which is symptomatic. So you don't want to do something about it, but it's an interesting thing. Some people have operated on it with variable results, but it's not a good thing to operate on. But the syringomyelia is secondary to the destruction of the spinal cord, and it's not a primary pathology like you have in the Chiari malformation, which is associated with syringomyelia. There it's the CSF which is entering into the spinal cord and enlarging the spinal cord. So one good clue to that on an MRI would be if you have syringomyelia in the spinal cord, but you do not, if you have the spinal cord enlarged, then you know that it's a symptomatic one. But if the spinal cord looks about the same size or it's shrunken, then you know it's probably secondary to trauma.
The bottom line is, yes, you theoretically get the syringomyelia out of whiplash, but like Dr. Dadlani said, it's the manifestations of the symptomatic manifestation might not be as much as
Yes,
common as Chiari
and Chiari malformation.
So the most common manifestation would be in Chiari malformation. So most
Yes.
of them would produce syringomyelia. Your question is right, and the answer to that is yes, most of them would cause, but symptoms are seen more in Chiari malformation. Right?
Yeah, and in the trauma, the symptoms are mostly due to the injury per se. That's the primary pathology, not the syrinx. So, in a whiplash injury? So usually, like I said, the syringomyelia does not cause the symptoms primarily. Even if you see it, it's more like a radiological sign that you see. And it's very important because as a surgeon for us to distinguish, we sometimes see syringomyelia in people who've had relatively minor injuries. And they really have to scratch their brain, like, did I have an injury? When I ask them, do you have an injury? And they are not sure. But it looks like one of the syringomyelias in which the spinal cord is not enlarged. So in the other KRE malformations or the other causes of syringomyelia, you have to have an enlargement of the spinal cord. When that happens, the syrinx is symptomatic. It's pushing the spinal cord out. But in the traumatic one, not really. So you don't get too many clinical manifestations from that. It's primarily the symptoms continue, the symptoms and sign like before. Like our patient's quadriplegic, he continues to be like that. And you don't develop new sensory findings secondary to the syrinx. That's very unusual.
But you still get a vignette so that you know that the question, the reason why it's asking is because you always talk about the pain temperature dissociation, right? So you've got the ventral hemisphere that goes very close to the central canal. So you could have that shower-like manifestations, syringomyelia manifestations because of involvement of those depositions.
Again, rare. In trauma, it's rare. I don't see much of that clinically. I don't see that. We see a lot of traumatic syringomyelias because relatively minor trauma can sometimes cause a syrinx. But, because it's important for me to distinguish, will this patient be helped by surgery or not? Any more questions? No.
Yes, 4 more minutes.
4 minutes. Yes, we're going to have a couple of classes on cranial nerves yes. And after we're done with the cranial nerves, then we do the review syndromes. We'll do a bit of review of the entire brainstem with the cranial nerves. We'll try and squeeze that in maybe a short class. And then the next lecture after that would be brainstem syndromes. Yeah. Syndromes, yeah. So you.
Feel free to send him email. Send us email. If you have any questions
Yeah.
or you want to ask him to review, he will happily do that.
Yeah, that's no problem. Anytime, yeah. Yeah, sure.
He has not seen the mullet yet.